Hi, and welcome back. This is lesson 9. So, in lesson 9, we're going to be talking about troubleshooting and problem solving in CT. Because in CT, we typically do run into some problems. So, I'm going to go ahead and dive in and kind of explain how to kind of correct some of these problems and, just kind of get ourselves out of the, oh my gosh, what just happened? Now, protocols, adjusting them in real time. Okay, now we know that sometimes CT exams don't always go as planned. Okay, so let's say there's not enough, KVP, patients are underexposed, or the contrast bolus is not so great, the timing was off. There's all kinds of things that don't go as planned. Okay, so here's the thing, it's okay to adjust your technical factors as this will affect patient dose. Okay. So let's say if you have a patient, you don't have any bariatric protocols on your scanner and patient's a little underexposed. So if it's okay with your site to adjust your technical factors, let's say bump up the KV or bump up the MA, not both guys, you have to do one or the other. Okay. So sometimes we can adjust our technical factors, being conscious of patient dose though, but sometimes, you'll get a radiologist that'll say, can you go ahead and increase, your MA to X, Y, and Z because this image is underexposed and I need you to rescan the patient. But make sure that your site allows you to do this. I know currently where I work, we are not allowed to adjust technical factors because they have built bariatric protocols and different protocols for peds to accommodate this. Okay. Use bariatric protocols if needed and if they are available on your scanner for larger patients, because this will compensate and you'll get better image quality for that. So there are special protocols for bariatric patients that you can use if that exists at your site. And I think most facilities do have this because we do have like pediatric protocols, we have bariatric protocols, and then protocols, for everybody, just generally, right? So if you can, because sometimes the case does call for it, use them. And then, of course, there's pediatric patients. Most sites have protocols for peds, and they're usually categorized by weight. I know at our facility, we do have our pediatric protocols, and it's by weight as far as like how much the patient weighs. So we take that into a factor. And also contrast, when it comes to contrast with peds, we do that 1 cc per pound as far as what the weight is. What I strongly suggest is utilizing your site's protocol book is a useful tool and resources, or sometimes asking the radiologist because they can be very, very helpful when it comes to this. Now, we also have patient motion and artifacts. Now, not every patient that comes to CT is going to be cooperative. They're not going to be alert. A lot of them have altered mental status, dementia, Alzheimer's. They're combative. They're not cooperative. Some of them, we've got patients who have disabilities, patients that may be blind, patients that are hard of hearing. So we have to take into account and be mindful of how to go ahead and take care of these patients. So instructions to the patients to not move during the exam is super vital. If they're alert and oriented, they can understand your your requests to just not move during the exam and just respond to all questions they can answer. It's very, very helpful. In cases where we have patients with dementia and things like that, we just have to do the best we can, okay? Sometimes I know I had a patient who she didn't like any of us and she had Alzheimer's. She didn't know where she was. She didn't know anybody, only knew the son. So we brought the son into the room and asked him to help us so we can get the scan because he said that she was getting worse and he was worried about her. She had a history of stroke and we needed to get the scan done on his mom. So he was very useful and very helpful to us to accomplish that. And he thanked us all for, helping, getting this accomplished. And I said, we couldn't do it without your help. So sometimes family can calm the patient down and try to have them at least try to cooperate for the exam. Now, we do have immobilization tools. There's cable straps, there's sponges for head positioning, head straps, when we do head CTs. They can be helpful to minimize the motion. I would say utilize all of it just to try to get the best scan that you can. And then make sure you're aware of repeat scans and check with your radiologist. Let's say if the patient moved their head and let's say your hospital has a, policy, for example, this is just an example of, if you're going to repeat something, you have to call the radiologist and get approval. So if they do, lots of times, if it's just a few images, they'll let it go. But if it's extensive, I would call them and say, hey, here's the deal. I'm trying to get this on this patient. It's really difficult. And on 9 times out of 10, lots of facilities will just let us repeat it. My recommendation is just repeat the scan twice. And then after 2 attempts, call the radiologist and say, listen, the patient's not going to hold still. They can't sedate him. What do you want me to do? And they'll give you guidance on what to do. Common artifacts that we see in CT is noise because of body habitus. And so I was explaining bariatric protocols. So that is one of the things that we do, but we do have a lot of filters and, the way it's ran through the digital processor that tends to clean up a lot of that noise because of helical scanning. So in larger patients, we usually use a higher KV station with larger patients. We're talking about our bariatric, population. So that's usually one of the most common artifacts that we see is noise. Now we also come into contact with ring artifacts. So you'll see this nice little ring around your image, which you're like, okay, why is there a ring artifact? Now, 9 times out of 10, if you do an error calibration test and make sure nothing is in the field of where the X-ray tube is, it will clear up some of these. What I've found is that one time at a hospital I worked at many years ago, like the tech who would do the phantoms every morning and would leave the phantom inside the gantry as the air cal was going on. Well, all of a sudden we get a bunch of ring artifacts and the radiologist is like, okay, we got to figure this out. So what I did is I said, okay, let's not send for anybody because it's going to take 20 minutes. And I went ahead and ran another air calibration test. And all of a sudden the ring artifacts are gone. And the tech tells me, she's like, oh, well, I just leave the phantom. I was like, you can't leave the phantom in there. You have to actually bring the table all the way out to do the air color because that's the whole purpose of it. So make sure you don't have anything inside the gantry when you're doing an air calibration test, okay? Because then you'll kind of minimize the ring artifact. Now, if you're still getting ring artifact and you're doing your air cals correctly, then service might need to take a look at it because it might be a detector or something going on inside the X-ray tube or inside the gantry itself, okay? Now, sometimes we do get detector artifact. And what I've seen it look on a CT image, it looks like just a bunch of streaks on your image. And you're like, okay, what is that? Sometimes it could be a ring artifact too. So I've seen it where it's just a streak right across the CT image. So those need service. We can't really clear those up because those might be a detector problem and something needs to be fixed along the detector array. Now, another common artifact that we do see is beam hardening. So beam hardening, we usually see it typically on head imaging because of the petrous ridges and the skull is so dense. A lot of times you get beam hardening if the patients have had rotator cuff tears, they have broken extremities, and they can't raise their arms above their head for any body imaging. So, of course, x-rays have to penetrate a lot more through the shoulders, especially if you got a patient who's really big, it has to penetrate even more. So typically with head imaging, it's because of the petrous ridges. So that's why if your gantry is able to tilt, that's why we tilt away from the lenses of the eyes. 15 to 20 degrees to kind of minimize that. Now, we do get some technical errors and we can do some fixes when it comes to any types of problems. So some technical errors occur in CT and can be easily fixed. Okay, like for example, I just explained ring artifacts. If you can do an error calibration test, it will clear most of these up. And it's also important to do your QA daily, where we go ahead and write down all the numbers, the CT numbers, of water, of air and all that on your phantom. Those are things that are really important to do. And of course, there's beam hardening, just like I explained, okay? And we can, angle the gantry if your machine is able to do that. Now, I know newer systems, because R256, both of them, do not tilt. Okay, they do not angle at all. Okay, so it seems that these have been phased out as iterative reconstruction can improve this image quality, or we have something called a virtual gantry tilt, and it's a recon that's built into your protocol. So where you can take it and you can kind of angle almost at the same degree level of, what you would angle your gantry, and it'll create an image that way. So, because I know the newer 256s, they have a lot of the new 256 that we have has like all these AI components, which I don't fully understand because I'm an old school tech, so I kind of do things, the old-fashioned way. But it's always good to learn as far as, the new tips and techniques and use it to its full advantage. But yeah, you can use that virtual gantry tilt to kind of accomplish that as well. Now we have cords, monitors, other items. If you can move them out of the interest of the scan, if possible, that would be great. I know as far as like insulin pumps, I know there has been literature as far as that. And I know my hospital has a policy where we ask the patients to just kind of disconnect them, because I guess we had a patient who their insulin pump was ruined during a scan. I don't know how true that is, but they claimed it was. So now our hospital has a policy if the patients can disconnect it just for like a few minutes, just so we can get it out of the area of interest. Okay. If patients have like the cochlear implants, so usually I just have them remove the outer part so we can scan, because it does create artifacts. So anything that we can minimize any artifacts is good to move out of the way if possible. Now, when we have detector and tube failures, those are two things we cannot fix. Those are things that need service to fix, because obviously if you have an X-ray tube failure, you're never going to accomplish a scan. Like the scanner just stops working. So those are things that need like immediate attention, because there could be other potential problems on why there was a tube failure. Okay, so that is the end of lesson 9. We are coming to the end of this course, and I hope that you've learned a lot. I know this is a lot of information, but I think it's a lot of information just to kind of get you familiar as far as how to navigate your training in CT and how things are kind of, put into perspective. So in the last lesson, lesson 10, I'm going to give you some tips and some guidance on CT registry prep and career pathways. So stick around and join me in lesson 10.